Why do conditions like thoracic outlet syndrome occur at the thoracic inlet? Go figure. To answer this question, we must first of all understand the bony framework of the thoracic cage. What's up, ladies and gentlemen? Welcome back to Neurosketch with Dr. Kenny. And in this video, we are going to break down the anatomy of the thoracic cage, its bones, apertures, and key anatomical landmarks that make this region so clinically important. If you find this video helpful, don't forget to subscribe. Alright, folks, time to dive deep. The word thoracic cage is synonymous with the rib cage, and these two words, they refer to the same thing, which is the bony framework that protects the chest, the bony framework of the chest. We've been talking a lot about thorax. Why is it called thorax to begin with? So the word thorax comes from ancient Greek thorax, which means the breastplate. This is a breastplate. Why is this region of the body called thorax? It is because it protects the structures that are lying deep within the chest in a similar fashion as how the breastplate protects this part of the body, and so it is called the thorax. It is conical shaped and has the shape of a bird cage, and this is because the length of the rib is keeping on increasing from rib number 1 to rib number 7, but from rib number 7 to rib number 12, the size is keeping on decreasing. So this is the outer framework, which means inside it we have a cavity, and the cavity inside is called the thoracic cavity. So the thoracic cavity houses important vital organs, the heart, lungs, and some other major vessels, and this is within the thoracic cavity. As you can see, the thoracic cavity is bounded, surrounded by this bony framework, and this bony framework is what we call the thoracic cage. So what are the bones of the thoracic cage? Anteriorly, it is bordered by the sternum, posteriorly by the vertebral, by thoracic vertebra T1 through T12, but laterally we have the ribs which are connecting from posterior to the thoracic vertebra, but anterior to the sternum by the costal cartilage, forming this important region. Combining in the costal cartilage of rib number 7, 8, 9, and 10, they are forming the costal margin. So this is the costal margin, which is the curved cartilaginous lower border of the rib cage. Lower border, the curved cartilaginous border of the rib cage is known as the costal margin, and it is formed by union of the costal cartilage of the rib number 7 through rib number 12 The thoracic cage has got two important apertures, two important openings. And the first one is superior thoracic aperture and inferior thoracic aperture. Let's start with the superior thoracic aperture. The superior thoracic aperture, it is kidney shaped, oblique, and it measures about 6.5 centimeters in anterior posterior diameter, but on the transverse transverse plane it measures about 11 centimeters. It is kidney shaped. Why is it oblique? It's because the posterior border of the superior thoracic aperture, it is higher than the anterior border, so it gives impression of depression or oblique fashion. It's not transverse like horizontal transverse. No, it's oblique, and it's oblique because the posterior most portion is higher than the anterior portion. What are the boundaries of the superior thoracic aperture? It is posteriorly bordered by the T1 vertebra, T1 thoracic vertebra, but laterally by the first rib on the left and right side, but anterior with the costal cartilages, but anteriorly by the superior most part of the manubrium part of the sternum, manubrium sternum. Why is it important? It's important because it marks it serves as a connection between the anatomical structures between the neck and the thorax. If we have to, to get things into the thorax from the neck, they have to get through the superior thoracic aperture, and also we see that some of the structures are emerging out of the superior thoracic aperture. But we also have the inferior thoracic aperture, which could literally mean the inferiormost portion, inferiormost boundary of the thoracic cage, because you'd like to imagine the thoracic cage spans from the superior thoracic aperture to the inferior thoracic aperture. But as you can see, the outline of the inferior thoracic aperture, it is very irregular, but more spacious. It's so wider than the superior thoracic aperture. So what are the boundaries of the inferior thoracic aperture? Posteriorly by T12 vertebra, but as you're moving laterally by lip 12. After lip 12 you encounter the lip 11, and from lip 11 now you are going to the costal margin, the fusion of the lowest costal cartilage to lip number 7, and anteriorly by the xiphoid process, and then you are going in the similar fashion. So those are the boundaries of the inferior thoracic aperture, rib T12, rib number 12, rib number 11, and then costal margin, and here the junction between the xiphoid process and the body of the sternum, the xiphoid joint, and then you are moving laterally in the same fashion. The inferior thoracic aperture is always covered by the diaphragm, and it marks anatomical thoracic outlet. Bold the word anatomical thoracic outlet. As I've said, it's covered by diaphragm, and the diaphragm now spans and covers the inferior thoracic aperture, which means now the thoracic cage becomes a closed system. So we'll have the superior thoracic inlet, the superior thoracic aperture, and the inferior thoracic aperture. The inferior thoracic aperture almost closed by the diaphragm to separate the thorax from the abdomen. We'll have a discussion of diaphragm somewhere else. I will put the link. But the diaphragm, separates the thoracic cage from the abdominal cavity. So we have two cavities that are separated by the diaphragm. We are going to discuss them next time. But that's the inferior thoracic aperture. We have a concept of thoracic inlet and thoracic outlet that can be so confusing to students, also to clinicians, because it would be easy if the superior thoracic aperture could act as thoracic inlet and the inferior thoracic aperture as thoracic outlet. But as I've told you, the inferior thoracic aperture is acting as anatomical outlet. Why do I have this confusion? Let's solve this mystery for once and for all. This is the superior thoracic aperture. The superior thoracic aperture is acting as the thoracic inlet to non-circulating substances that are getting into the thorax. This is food in the esophagus and air in trachea. So food and air, they are using the superior thoracic aperture as their only way of getting into the thorax. In this fashion, the superior thoracic aperture is acting as thoracic inlet. What about arteries? Remember, the function of arteries is to carry blood from heart into the rest of the body. So the heart is already in the chest. So these arteries, they are carrying blood from the heart into these other parts of the body. So they are using the superior thoracic aperture as their way out of the chest, and in this fashion the superior thoracic aperture is also acting as the thoracic outlet. So the superior thoracic aperture can behave both as the thoracic inlet to this structure, but also as the thoracic outlet into arteries and T1 spinal nerves. T1 spinal nerves. And so clinicians could refer the superior thoracic aperture as thoracic outlet, but anatomists would refer the inferior thoracic aperture as the thoracic outlet. Why? Because we have some structures that are getting away from the chest into the abdomen, from the thorax into the abdomen by the way of the inferior thoracic aperture, which is closed by diaphragm, by diaphragm. Having known that the superior thoracic aperture could act as thoracic outlet, let's now discuss about the thoracic outlet syndrome. The thoracic outlet syndrome is actually, this is a syndrome that is led by compression of the structures that are passing through the superior thoracic aperture. Even though the word thoracic refers to the thoracic location, but the compression is not happening, the obstruction is not happening around the thoracic aperture, but somewhere away, as you're moving away from the root of the neck, away from the root of the neck. So compression of these neurovascular structures, these are the blood vessels as you've seen, and nerves, will result in thoracic outlet syndrome. What are the possible etiology, possible causative mechanisms of having this compression? Number one, we discussed in the previous discussion that you can have the cervical rib. In the cervical rib, see, it wasn't supposed to be somewhere around here, but because it's here, it occupies the space, and so it can result into compression of this neurovascular structure. So this is the most offender of the thoracic outlet syndrome, the most causative agent of the thoracic outlet syndrome. But you can also have the spasm of the scalene muscles. I told you in the previous discussion, we discussed the scalene muscles when you are doing the anatomy of the neck. But at this point, at least we know that the subclavian artery is passing between the two scalene muscles, the scalenus anterior and the scalenus medius. The middle, anterior and the middle scalene muscles. Between the anterior and middle scalene muscles, we have an artery here, and that is subclavian artery. So if you have spasm of these muscles, could result into compression of the subclavian artery, and also we have the trunks of the brachial plexus somewhere here, and then it can result into the thoracic outlet syndrome. But you can have space occupying regions like tumor, cancers. Because they occupy space, they can result into pressure, result into pressure or compression of these neurovascular structures, and it leads to thoracic outlet syndrome. Clavicular fracture, the fracture of the clavicle can also result into dropping of the shoulder, by some other muscles here, which will result into also the thoracic outlet syndrome. But also if someone has got trapezius insufficiency or trapezius paralysis, he or she, the shoulder can drop in a similar fashion and result into compression of the neurovascular structures, as it will result into the thoracic outlet syndrome. By those swimmers also, because they are doing the hyper abduction and external rotation, they also have risk of having the thoracic outlet syndrome, because the muscular bands will hypertrophy and result into compression of this neurovascular structure, resulting into the thoracic outlet syndrome. We have various types of thoracic outlet syndrome, but it's out of scope of our discussion. But because you see these structures are coming from the root of the neck, and they are almost all of them are going to the upper limb. So the clinical manifestation of the thoracic outlet syndrome will be on the upper limb. The clinical manifestation will be revealed on the upper limb, and it will include pain, swelling, and the loss of function. As you can see, this arm is almost adducted, but it's swollen, and it's probably painful. So the treatment of the thoracic outlet syndrome will depend on the severity of the situation. If the condition is not severe enough to warrant surgical intervention, it can be treated conservatively. But if the condition is so severe, it warrants surgical intervention. And the goal of the surgical intervention is to decompress, to remove the offending agent, the offender. For example, if the offender is the cervical rib, it has to be removed. But if the offender is a tumor or a mass or a cancer tumor, something, space occupying region, it has to be removed. But also if the offender is the muscles, for example, the scalene muscles, they have to be removed, as in a process called scalenectomy, removing the scalene muscles. We have another important region of the body here, of the thorax, which is called the cardiac box. This is the zone of the chest where the penetrating injuries will result into The penetrating injuries like gunshot result into life-threatening bleeding because of injury of potential damage to the heart and great vessels. I think soldiers know about the cardiac box. I'm just thinking, because why do they put on this vest, the bulletproof vest, if they didn't have an idea of a cardiac box? They know. Okay, assume they don't know, but why do they target, when they're doing the shooting, why do they target this region? Because this is one among the training that they are doing in their course. They are doing targeting and training targeting. Why do they target this region? Because they know at this region, when they're in war, if you shoot your enemy at this region, the likelihood of death is higher than outside. The likelihood here is higher, and this is why it's called a cardiac box. The science is changing now. Some literatures are suggesting removing this terminology, removing the cardiac box, but because lay people, soldiers and other lay people, they know about the cardiac box, you as a medical personnel and healthcare professional, you should also know the cardiac box. What are the boundaries of the cardiac box? It is bordered superiorly by the line through clavicles, but laterally by the line that passing midi-clavicularly through the midpoint of the clavicle. This line will also pass through the nipple, and inferiorly it's bordered. The cardiac box is bordered inferiorly by the line which is joining to the two costal margins. We also have another important thing here, which is known as the costovertebral angle. The costal means rib, vertebra. So this is the angle where the rib number 12 will meet the spine. The rib number 12 and the spine, they meet at the point here, and this point is called the costovertebral angle. This angle is important because it marks a location of kidneys, but the clinical repercussion, we are not doing it for fun. The clinical repercussion of the costovertebral angle, it is actually when the kidneys becomes inflamed. So when the kidney is inflamed, if you hit at the costovertebral angle, the patient will have tenderness, and this tenderness, we call it the costovertebral angle tenderness, but it is also known as the Murphy punch sign. What does it mean? It means if the Murphy punch sign is positive, if you hit, you are not palpating, you are hitting. If you are hitting at the costovertebral angle of your patient, the patient gets tenderness, it signifies he or she might have inflammation of the kidney, which is called the pyelonephritis. The Murphy punch sign should not be confused with Murphy sign. You might have heard of Murphy sign, which is palpation of the around the gallbladder, the region of the gallbladder, which results into pain. It's something different, and we discuss the Murphy sign sometimes later, but it should not be confused with the Murphy punch sign. Alright guys, this is what I had for you today. But as always, stay tuned, stay curious. I'm going to drop another video really soon, and so don't forget to subscribe, share this video if you like, share this video to your friends, and stay tuned.